Good evening, everyone. Hello, and welcome to today's session, a webinar on projecting the new trends in dentistry and oral health, organized by Asia Pacific Association for Dental and Oral Health and scientific partner BioLease and our research partner United Innovators. Asia Pacific Association for Dental and Oral Health is one of the leading professional associations committed to improving dental and oral health by promoting advanced science-based evidence through our initiatives in education and research. Oral and general health are related and are key indicator of overall health, well-being, and quality of life. Dental caries, periodontal disease, tooth loss, oral cancer, and oral manifestations of multiple illness, oral dental trauma, and birth defects such as cleft lip and palate are among the disease and conditions covered. The leading non-communicable diseases share modifiable risk factor with almost oral diseases and conditions such as cardiovascular diseases, cancer, and chronic respiratory diseases. Tobacco use, alcohol consumption, and unhealthy diets rich in free sugars are among the risk factors of all which are on the rise of globally. So today we have gathered with our two speakers, Dr. Sumit Gupta and Dr. Sheetal S. Choudhary. Dr. Sumit Gupta, MDS Ortho, Diplomate of American Board of Oral Facial Pain, founder RAK Dental Care and Implant Center, UAE. Dr. Sumit Gupta is licensed as a specialist orthodontist and certified Invisalign and Incognito provider by Dubai Health Audit Authority Consulting in Dubai and Abu Dhabi. For more than 23 plus years, he treated more than 15,000 orthodontic patients. He passed in National Dental Board Examination, USA, completed his study of sleep medicine and mastership from Roseman University, University of Dental Medicine, USA. He is a gold medalist, stood first in the university in all branches of dentistry, along with various publications and case reports. He is also an orofacial pain physician, specialist in management of TMJ disorders, musculoskeletal, and others. He's having a special interest in laser dentistry and believes in painless dentistry. Sir will discuss about the topic, dental management of sleep disorders. Sir, the stage is all yours.
Yeah, thank you, Laiba, for the kind introduction. Thank you, APADENTO and all the organizers for giving me this opportunity. I'd just like to share my screen. Are you all able to view my screen?
Yes, sir.
Okay. Okay. I'll be talking on dental management of sleep disorders. This talk on dental management of sleep disorders. The learning objectives of this talk, which will help us to know the common sleep disorders which are important in a dental clinic, the anatomic risk factors in the pathogenesis of sleep-related breathing disorder like OSA, the role of dentists in diagnosing and managing snoring as well as OSA, and oral appliances have a role in treatment of these disorders. As you would all be aware, orofacial pain has been recognized as a specialty in dentistry. It is the 12th specialty in dentistry, and it has been added by the American Dental Association as well as the Committee on Dental Accreditation. And this landmark decision was made on the 31st of March 2020, and a huge field of orofacial pain, which is an emerging specialty and which bridges the gap between medicine as well as dentistry, has come under the umbrella of dentistry. So what is orofacial pain? According to the International Association for the Study of Pain, it is pain perceived in the face and or the oral cavity, which is caused by diseases or disorders of the regional structures, dysfunction of the nervous system, as well as through referral from distant sources. The scope of orofacial pain is enlarging, and it's an emerging specialty, as I said, and at present, orofacial pain encompasses temporomandibular joint disorders, masticatory and cervical musculoskeletal pain, neurovascular pains, sleep disorders, orofacial dystonias, all sorts of headaches, and other systemic disorders. And today I'll be talking on sleep disorders which are related to orofacial pain. Today's medicine as well as dentistry has to be science-based, literature-based, research-based. And my today's talk is totally evidence-based. And any of you would like to have citations or references to any of my slides, please feel free to contact me. I would be happy to send you across. So sleep disorders, they are one of the most common health problems. Yet 80 to 98% of the sleep disorders go undiagnosed. Chronic sleep disorder patients are chronic sufferers and have impaired health and daily functioning issues. The role of the dentist is becoming more apparent in the recognition of these disorders. And we dentists play an important role in co-managing these disorders like snoring and OSA. So what is sleep? It's a universal necessity of all humans, and approximately 1/3 of our human life is spent in the sleep stage. What are the functions of sleep? It helps for fatigue reversal. It helps an individual to recover and re-energize. It helps in the growth. The growth hormone peaks during sleep, and so sleep is really important for the growth of a baby. It helps to prevent and fight illnesses, helps in memory consolidation, and it's important for the psychological well-being. Sleep has been divided into different sleep stages, and right from the time lights off when you hit bed to the first stage of sleep is known as sleep latency, and it is about 15 to 20 minutes approximately. Then are the N1, N2, and the N3 sleep stages, which are also called the slow wave sleeps or the NREM sleep stages. Then comes the rapid eye movement sleep stage, which is also known as an active stage of sleep or a paradoxical stage of sleep, in which most of the body is in a hypotonic state and it's paralyzed except for the eye muscles as well as the diaphragm, which helps in breathing during sleep. The typical pattern in normal sleep is for the individual to progress from wakefulness to NREM sleep state, followed by the REM sleep, and this cyclically alternates. Every cycle is approximately 60 to 90 minutes. When this cycle becomes irregular or there's deprivation of the NREM sleep stages, sleep disorders can develop. Sleep-related breathing events such as apnea and hypopnea are usually observed in the N2 as well as the REM sleep stage. How much sleep do we need? It varies between 6 to 10 hours. Babies sleep about 10 to 12 hours. And anything which is too short, less than 4 hours, or too long, greater than 10 hours, is conducive to cardiovascular attacks, diabetes, obesity, depression, and even cancer. Why is sleep medicine important? Sleep apnea has been shown to cause, aggravate, and perpetuate refractory hypertension. It has a significant association with metabolic syndrome, type 2 diabetes, ADD or ADHD in children, stroke, as well as coronary heart diseases. Pain and sleep, they have a bidirectional relation. Pain influences sleep and vice versa. Lack of sleep can be associated with bad sleeping habits or health issues like anxiety, depression, persistent pain, and even cancer. It has been shown that sleep deprivation may trigger mood alteration and can initiate diffuse pain complaints in healthy subjects. Similarly, orofacial pain and sleep have a strong association, and about 50% of the orofacial pain patients, including patients with TMJ pain, report poor quality of sleep. And we dentists should be aware of this complex interplay, and a professional collaboration between us and the medical doctors is what is needed. Here I am on completion of my fellowship in orofacial pain and dental sleep medicine, and then my master's. This is Dr. Gary here, the past president of the American Board of Orofacial Pain. Dr. Davis Thomas, my mentor, my guru. That's Dr. Frank Licari, the Dean of Roseman University in the US, and Mr. Mukesh Ambani, the Chairman of Reliance Industries. So sleep disorders, they are no longer be thought in simple terms as having a poor night's sleep. And there are a large number of different sleep disorders. And according to the International Classification of Sleep Disorders, there are about 85 different sleep disorders in about 8 different categories. And the one of paramount importance to the dentist are the sleep-related breathing disorder, which is snoring and OSA, as well as sleep-related movement disorder. We'll just have a look at this short video. Yeah, so watching this is hilarious. Sleeping next to the person who snores is really annoying, but for the snorer per se, it is life-threatening. So what is snoring? It is respiratory sound produced in the upper airway during sleep that typically acoustic nuisance, which we just saw. It is the most common reason for sleep for referral to sleep laboratories. It can be called as primary snoring or benign snoring. The prevalence of snoring is really high, and children, yes, they do snore as well. And the prevalence of snoring increases threefold during pregnancy. Snoring is a marker for OSA, and snoring and OSA are part of the same disease spectrum and have similar underlying mechanism and cause. What is the mechanism of snoring? It is generated at the level of the upper airway, and it's associated with vibration of the soft palate and the restriction of air passage with noisy air turbulence. What are the health effects of snoring? It is more than just a bedtime annoyance. Most commonly, it causes excessive daytime sleepiness. This causal relationship between snoring and hypertension, association between snoring, cardiovascular disorders, and stroke has been seen. Snoring progresses to OSA most of the times, and it predisposes to thickening or abnormalities of the coronal arteries. Sleep apnea, it's a sleep disordered breathing disorder. It can be either obstructive or non-obstructive. Under obstructive breathing disorders are the upper airway resistance syndrome and the obstructive sleep apnea itself. Non-obstructive can be either central apnea or the hypoventilation syndrome. OSA is a disorder in which patient is trying to breathe normally but cannot. And because of the mechanical obstruction of the airway, it typically involves an airway obstruction that results in an increased respiratory effort and insufficient ventilation. It is characterized by a repetitive, complete or partial collapse of the upper airway during sleep, causing a cessation or a significant reduction of airflow. Central sleep apnea is a disorder in which breathing repeatedly stops and starts during sleep due to lack of respiratory effort, and it is related to a cardiac problem or a CNS dysfunction. And we dentists do not play any role in managing this. A stat referral to a neurologist or a pulmonologist is what is required. The upper airway restriction syndrome, it is characterized by a partial collapse of upper airway without the occurrence of obstructive apnea and hypopnea. And it's an intermediate form between snoring and frank OSA. Here we see the evolution. It starts with occasional snoring, becomes habitual, leading to UARS, occasional apnea and hypopnea, ultimately developing into a frank OSA. So OSA is an inflammatory disorder. It's an oxidative stress disorder, an atherosclerogenic disorder, a metabolic disorder, as well as a societal disorder. Here we see the sagittal section of the upper airway, which is composed of hard and soft tissues. The upper airway is a tubular structure which is highly collapsible, and the soft tissues lack a rigid backing. And this allows the occurrence of OSA in susceptible individuals. The upper airway is is divided into the naso, the velo, oro, and the hypopharynx. And the most common site of upper airway collapse in OSA is the velopharynx, which is from the soft palate to the uvula. What happens when we sleep? When we lie down, the upper airway is more vulnerable to collapse because of the gravity. The tongue falls back and so does the jaw, and there's relaxation of the pharyngeal dilator muscles. These are the muscles attached to the hyoid bone, the tongue itself, the palate, as well as the mandible. And this causes the airway to be partially or completely blocked. What is the pathophysiology of OSA? It is multifactorial, and the activity of these dilator muscles plays an important role. When we are awake, these muscles compensate for the anatomic deficiency in the upper airway. This compensatory effect is substantially diminished when the action of the upper airway reflexes and pharyngeal dilator muscles decreases during sleep, and in particular during the REM sleep stage. There are a lot of adverse outcomes of OSA. To start with, they can be neurocognitive, which causes excessive daytime sleepiness, increased risk of motor vehicle accidents, poor job performance, family discords, impaired quality of life, depression, cardiovascular like hypertension, CHF, stroke, and even death. Or they can be metabolic, which is impaired glucose and lipid metabolism and systemic inflammation. What are the predisposing and precipitating factors? Obesity is one of the main risk factors. In children, OSA is usually related to enlarged tonsils or adenoids or to maxillomandibular malformations. Increased neck circumference is a predictor for OSA. Male preponderance, menopause and truncal obesity in females, certain hereditary and acquired abnormalities, hypothyroidism, adults Down syndrome, alcohol consumption and sedatives such as benzodiazepines contribute to upper airway obstruction by relaxing the upper dilator muscles. Rhinitis, nasal congestion, GI reflux. I'll just like to mention for patients with GERD, this is concomitant with sleep apnea, and it is therefore important to exclude respiratory disorders in patients who report to us dentists with chief complaint of erosion of the teeth, which is caused by GERD. Distribution of fat around the neck and the waist is known as central obesity, and fat deposits in the neck puts outside pressure on the airway tissues, making it more narrow. And the tongue also contributes, a large tongue by obstructing the airway. So diagnosis should be based on a comprehensive sleep history, the presence of characteristic clinical features and predisposing factors, and an objective demonstration using a polysomnogram, which is a sleep study done overnight in a sleep lab. The Epworth Sleepiness Scale is the most frequently used for subjective self-assessment, and it determines a person's level of daytime sleepiness. Different situations such as sitting and reading, watching TV, sitting inactive in a public place, or sitting quietly after lunch, or even stopping for a few minutes in a traffic while driving are given to a person, and his chances of dozing off are graded, and the level of sleepiness scored. Any score from 16 to 24 is considered to be excessive daytime sleepiness. Another questionnaire which is routinely used is Top Bank questionnaire, which is used to assess a person's risk of OSA, where S is for snoring, T is tiredness, O is observed apneas, P is high blood pressure, B is the BMI if it is greater than 30, age above 50, the neck circumference for males greater than 17 inches or for females for greater than 16 inches, and the male gender. It's very important during our history-taking part to have these conversations with our patients, asking them whether they feel tired throughout the day, whether they snore, do they feel groggy even after a full night of sleep, have they experienced memory loss or having difficulty concentration, or do they become out of breath even after walking up a flight of stairs? The bed partner's history is really important, but don't ask someone who snores himself or herself or who sleeps earlier, because there'll be snoring festival on the bed and both will be happy campers. So in such cases, either videos or audio visuals will be of real help. The polysomnogram is considered to be the gold standard, which monitors occurrence of apnea and hypopnea and associated arousals. It is an overnight sleep study done by a sleep technician in a sleep lab and is considered to be the gold standard. A PSG consists of an EEG, an EOG, EMG, and ECG, along with a pulse oximeter. And as I said, it can be done overnight in a sleep lab. This is how it looks, or it can be done in an in-house study. But definitely, an overnight sleep lab study done in a sleep lab is more reliable and diagnostic. Some important terms which we should be aware of. Apnea is cessation of breathing for more than 10 seconds. Hypopnea is a reduction in the airflow accompanied by arousal or drop in oxygen saturation. Based on these two, the AHI index is calculated according to the number of apneic and hypopneic events per hour of sleep. And nowadays, we use the respiratory disturbance index, in which the respiratory effort related arousals are also taken into consideration. Accordingly, OSA is graded. If an AHI is between 5 to 15, it's mild. For an AHI between 15 to 30 is moderate, and anything above 30 is severe OSA. So we dentists play an important role in diagnosis of OSA because of the high frequency of contact intervals and the regular observation of the oropharyngeal structures in the supine position. This slide shows us the role of various dental specialists in the assessment and measurement of OSA. Each and every specialty plays an important role. This was a study done by Lobezo and Levine in August 2020. So the evaluation by the dentist consists of a detailed history taking the medical history, past and current medications, TMD assessment, oral and nasal evaluation. The SRBD history consists of asking the patient for any snoring, witness apneas, nocturnal chokings, low energy levels, daytime sleepiness or tiredness. If the patient has difficulty in concentration, mood swings or irritability, depression. Morning headaches, this is one of the main symptoms of OSA. Patient complains of headache upon awakening, and this usually disappears within 30 to 45 minutes or so as the patient walks around. The extraoral examination, we look for dark patches under the eyes known as venous pooling or allergic shyness. Stuffy congested nasal passages lead to congestion in small blood vessels under the eyes, which causes dark puffy areas. A retrognathic upper jaw, as well as a retrognathic lower jaw, which reduces the pharyngeal airway. A large neck, we just discussed. Forward head posture, it is related to a poor airway and tender head and neck muscles on palpation, and mouth breathing can lead to such a postural change. Craniofacial pain exam, if necessary, is done. We look for the mouth opening. We see for any deviation or deflection. Lateral and protrusive movements, the eccentric movements. We see for TMJ tenderness and sounds. Neck movements, we check whether the cervical range of motion is restricted, and muscle palpation is done to see for any tenderness or any trigger points with referral are there. Importance of nasal evaluation, it helps us to rule out any nasal obstructions or deviated nasal septum. Intraoral examination consists of looking at the dentition and the supporting structures, the kind of malocclusion patient has. Definitely a class 2 diff 2 occlusion with a deep bite, retrocline maxillary incisors is definitely patient is at risk of having OSA. A narrow, high V-shaped palate, which is caused due to mouth breathing. Chronic mouth breathers have poor lip seal and they have dry, chapped lips. We look for bruxism, look for worn out teeth with attrition. Mandibular tori, because of excessive parafunction, this can cause an impingement of the oral space for the tongue. Abstraction lesions and recession. Check for the tonsils if they are enlarged or grossly obstructive, especially the grade 3 and grade 4. The grade 4 are the kissing tonsils, where the tonsils are almost touching each other, and this causes a high incidence of airway obstruction. Looking at the tongue, we see for macroglossia, which increases the potential for upper airway obstruction. A coated tongue, which is a possible indication of GERD. Scalloped or serrated tongues, which is seen usually in nighttime clenchers and grinders. A fissured tongue, as well as a tongue tie or ankylosglossia. We see for the uvula, if it is enlarged, swollen, or elongated. The soft palate, again, enlarged, swollen, or it slopes downward into the oropharynx. Check for the gag reflex. This is important. If it is exaggerated, makes impression taking difficult, and it also decreases the compliance of the patient with oral appliances. Mallampati score, this is an important indicator for OSA. It was introduced by an Indian-American anesthesiologist, Dr. Mallampati, to predict the use of endotracheal intubation. But now it has been used globally to assess the incidence of OSA, and with the patient's mouth wide open and the tongue resting inside, we look for the oropharyngeal crowding. Grade 3 and grade 4, where the airway is obstructed and hardly it's clearly visible, is a definitive predictor for OSA. Treatment should be based on accurate diagnosis and should be evidence-based. This is what our patients are demanding nowadays. And the OSA treatment should consist of behavior modification, CPAP, oral appliances, pharmacological treatment, surgical treatment. Behavior modification consists of altering the posture while sleeping, avoiding alcohol, minimizing the use of sedatives, cessation of smoking, as well as weight loss. Just to brush up the sleep hygiene plays an important role, avoiding caffeine like coffee, tea, chocolates, some painkillers 4 to 6 hours before bedtime, quit smoking, a quiet, dark, cool place with comfortable pillow and mattresses, and refrain from all blue lights, keeping away all the gadgets at least a couple of hours before bedtime. Relaxation before bedtime is really important, either taking a bath, reading a book, or listening to light, soothing music, and avoiding stressful, stimulating activities like workouts, emotional issues, or even arguments. Always sleep when you feel tired. Set your body clock with a consistent sleep schedule. A light supper or dinner several hours before bedtime, and avoiding heavy meals, oily foods, which cause indigestion. A balanced water intake. Exercise helps promote restful sleep if done several hours before bedtime. And being consistent is really the key. Obesity is the single most significant risk factor for OSA, and weight loss is the most difficult to achieve. Consistency is the key. It helps to reduce severity and symptoms. It reduces the pharyngeal collapsibility. Dietary modifications and regular exercises are recommended. Alcohol has a biphasic response. Initially, it makes a person drowsy, but later it destroys sleep. It increases sleep fragmentation. It delays REM sleep. It reduces the pharyngeal dilator muscle tone, making the pharynx more floppy. It induces snoring in non-snorers, induces OSA in snorers, and it worsens OSA in OSA patients. Ultimately, it destroys sleep. Surgical treatment, there are a lot of surgical options available, but as you all know, surgeries have their own risks and complications, and they are quite invasive, especially the UPPP, which is known as uvulopalatopharyngoplasty. It's a procedure that removes the excess tissue in the throat to make the airway wider. It's really painful, would definitely not recommend for my patients. Maxillomandibular advancement surgeries, which our oral surgeons are routinely doing. Maxillary expansion, which we orthodontists do using Hyrax maxillary expanders, or nowadays what I use are the implant-assisted expanders, which open up the mid-palatal suture without any surgical intervention and can be used even for adult patients. They give excellent results. CPAP, which was developed in the early 1980s, and it's the gold standard for the treatment of OSA. It maintains constant pressure along upper airway during inspiration as well as expiration, and patients with severe OSA get the most benefit. These are the different types of CPAP masks which are available. Patient chooses according to their comfort and convenience. Nothing comes without disadvantages. CPAP has its own disadvantages, and there are quite a few of them, claustrophobia being the major one. These disadvantages has led to the advent of oral appliances, and they have emerged as an alternative to CPAP for snoring, as well as for mild to moderate OSA patients who refuse or fail to adhere to the use of CPAP devices. There are different types of oral appliances. Mandibular repositioning appliance, which helps to advance the mandible forward. There are tongue retained devices which hold the tongue in an advanced position. They can be used in patients who are edentulous or who are periodontally compromised. They have their own side effect, causing sore tongue and an altered taste. Soft palate lifters, when the patient wears them, the palate is lifted up, thereby increasing the airway. There are certain requirements of these appliances, at least the presence of 8 to 10 teeth in each arch, and a minimum 5 millimeter protrusive capacity of the mandible is required. They must be custom made and they must be titrable. Indications we just saw, there are certain contraindications like poor dental status, inadequate healthy teeth, active periodontal diseases, and severe temporomandibular disorders. There are certain advantages of oral appliances. They are non-intrusive. They lack noise, unlike the CPAP, which is really noisy. They are simple, the reversible treatment modeling. They are smaller and more portable. No need of a power source. They are comfortable and definitely less expensive. So how these appliances work? They reposition the tongue and the mandible forward and reduce the airway collapse. They widen the lateral aspects of the upper airways to improve the upper airway space by mechanically stretching the palatoglossal and the palatopharyngeal arches. Here we see the figure on the left shows a sagittal view of a patent airway. And the right figure shows a collapsed airway because of the fall of the tongue and the mandible. This figure shows an oral appliance in place, which helps to move the jaw as well as the tongue forward. And this opens up the airway and helps to reduce sleep apnea. There are different gauges available to do the bite registration. What I use is the George gauge, which is very economical and very simple to use. A bite registration is done, impressions made, and then we send it to the lab for manufacturing the appliance. There are certain side effects of these oral appliances, which causes excessive salivation or sometimes dry mouth, TMJ or myofascial pain or discomfort, sometimes gum irritation, TMJ sounds, some morning after occlusal changes. But all these changes are very transient. These are some of the sleep appliances which I routinely use: the TAP 3 silencer, the modified herbs. So screening patients for OSA, it begins with the dentist. The most critical part of implementing OSA treatment in our dental clinics is to begin screening each and every patient immediately. There's no excuse for waiting. Don't be afraid to start. Set a goal of screening 100% of our patients. What does screening lead to? It makes more patients being tested and diagnosed. Successful cases, patients telling family and friends, involvement of the local medical doctors, increased referrals and we see happy patients and ultimately happy dentists. So the dentist's responsibility is to screen patients and identify these patients who are susceptible to OSA, make an appropriate referral to a sleep lab to get a PSG done. When it is diagnosed and indicated, we start with an oral appliance. The physician's responsibility is to diagnose and determine the severity using a sleep study, determine treatment, and when necessary, refer to us dentists for an oral appliance. Well, I started screening all my patients from 2018, and believe me, I see dentistry totally from a different perspective today. It has made a huge difference in my practice, with a lot of referrals from fellow dentists, medical practitioners, a lot of happy patients, and I would urge you to do so as well. So what's the take-home message? OSA is a chronic medical condition which can have serious medical consequences. Increasing the incidence of obesity has made OSA a growing phenomenon. Primary snoring is also a disease which progresses to OSA. The number one reason for morning headache is OSA. We could be the first medical professionals to identify OSA. Although CPAP remains the first line of treatment for sleep apnea, there's an important role for mandibular advancement devices. A collaborative and interdisciplinary effort is required to provide comprehensive care for such patients. And it is extremely important, I would say, that each and every dental practitioner should include a sleep history as part of their routine case history charts. So from today, I will say, think beyond teeth, observe beyond occlusion, practice beyond position, and care beyond cure. And this will help us and make each and every one of us top clinicians. A special thanks to my guru, my mentor, Dr. Davis Thomas. He has been a phenomenal mentor, an awesome teacher, and it is all because of him I'm here today. Thank you so much, Dr. Davis. Thank you very much. Thank you for your patience for listening to me. If you have any questions, please let me know. If you want some references, these are the references. Thank you.
Thank you so much, sir. It was indeed enlightenment for us. And we are pleased to have you here.
Thank you so much.
So moving to our next speaker, Dr. Sheetal S. Choudhary. She is an associate professor, Department of Oral and Maxillofacial Pathology, Yerala Dental College and Hospital, Navi, Mumbai. Dr. Sheetal S. Choudhary is currently working as an associate professor with an experience of over 20 plus years. She is involved in various research activities, workshops, and also having the experience in frozen reporting. She also got a grant approved from long-term research by Maharashtra University of Health Science. She was a guest speaker for various conferences, secretary in review boards, session chairs, and organizing committee members in various international and national conferences, along with more than 20 presentations and awards. She is also having 9+ publications and has authored 2+ books. Her contribution have also extended as an editorial and review board member for the International Index Journal. Ma'am will be discussing about changing trends in diagnosis of oral precancer and cancer. Ma'am, please unmute yourself.
Yeah, sure. Thank you, Leba, for such a kind introduction.
Thank you, ma'am.
Yeah, may I share the screen now?
Yes, ma'am.
I hope it's visible and I'm clearly audible.
Yes, ma'am, it is visible and you are audible.
Thank you. Thank you. First of all, I would like to congratulate Dr. Sumit Gupta, sir, for such a wonderful session. And a very good evening, everyone, and warm regards to all the significant, respected dignitaries, clinicians, researchers, and dear students. First of all, I would like to congratulate Team Asian Pacific Association for Dental and Oral Health for this great initiative. We know that this association is a non-profitable professional association which encourages dental professionals to share their research and innovations. I would like to thank them for providing this platform and giving the opportunity. To start with, whenever there is a new problem area defined in clinical setting, researchers try to find solution, and this provides a unique approach to the problem, and through their research, they provide better lives. In cancer research also, researchers have tried to set new trends through their research, and this changed the way we find, visualize, understand, treat, and prevent cancer. What was once thought to be impossible a decade ago in cancer research is a reality now, thanks to the number of innovations that has led to these major breakthroughs. Thorough understanding of the immune system, genetics, and cancer pathology has actually opened the doors to an ever-increasing range of cancer treatments and diagnostic tools. Since the discovery of BRCA genes, our understanding of cancer has sparked a new area, new wave in cancer research, which has profoundly impacted the diagnostic approach towards cancer. Researchers have also tried to set new trends in cancer therapeutics. In fact, 2000 has also marked the emergence of targeted therapies. Target therapies have, all these target therapies have improved the survival rates in various cancers. Also, the diagnostic approach towards cancer is changed through research. AI mammograms, at-home urine test for prostate cancer, liquid biopsy, cancer genetic testing in embryos are just few examples of the changing trends in cancer diagnostics. In fact, target therapies and precision medicine has revolutionized the area of cancer research and has generated a lot of hope and excitement among researchers and clinicians. When we look at oral cancer research developments, there are major breakthroughs. Rush biopsy, chemiluminescence, and autofluorescence-based oral optical diagnostics, EGFR-based target therapies for head and neck cancer are to name a few. So these breakthroughs are important, but are not enough. Why? Because we are still stuck at the poor survival rates for oral cancer. In spite of oral cancer being so visible and cause-related, we could not improve the mortality and morbidity associated with oral precancer and cancer. Having said that, how can we improve the mortality and morbidity? How can we have a better diagnosis and therapeutics in oral precancer and cancer? I think we need to change our approach towards oral cancer research. Our approach needs to be a more problem-based. We as clinicians actually are very closely associated with the complexities associated with the diagnosis of various oral potentially malignant disorders and oral cancer. And therefore, we are at the most advantageous position to come up with path-breaking ideas to solve the problems which we face in our clinical settings. To mention a few, when we look at oral precancerous conditions and lesions or oral cancer as a clinician, what problems do we face? OPMDs or oral precancerous lesions and conditions, they have very varied presentation. When I come across an oral potentially malignant disorder, I cannot predict the cancer risk in that particular patient. Also, when oral cancer patient is treated, we are not having significant markers which can predict the oral cancer prognosis, the prognosis for that particular patient. So there is lack of clinical tests available which can predict the prognosis in oral precancer and cancer. Though we are having these current screening and diagnostic tests like clinical examination, definitely tolerant blue staining, brush biopsy, and finally histopathology, definitely these help in the diagnosis and management of oral precancer and cancer, but these procedures are associated with certain limitations. Like our oral examination is associated with overdiagnosis or underdiagnosis, can give us false positive findings, and therefore the patient's treatment can suffer. With vital staining, there are no randomized controlled trials, and there is a lot of subjectivity which is associated with tolerant blue staining. Definitely, exfoliative cytology and brush biopsy can be conducted for oral cancer diagnostics, but it has to be confirmed with biopsy. And scalpel biopsy has got its own limitations, though it is a confirmative procedure. The limitations are it's an invasive procedure. We can assess the cancer risk in a particular oral precancerous lesion or condition through dysplasia, but dysplasia itself is associated with a lot of inter-observer variability, and the grading of dysplasia is also very, very subjective. Just to give you an example, like in case of breast cancer, it's a routine protocol. On biopsy, they do immunohistochemical analysis of certain markers like ERPR, that is estrogen progesterone, as well as CR or HER2. On the basis of the expression of these markers, the treatment modality is planned. The treatment is planned, and that affects the survival of the patient of breast cancer to a larger extent. But for oral precancer and cancer, we are still stuck at H&E staining. So just to have a solution to these clinical problems, we first need to analyze our problems. We need to be very specific about these problems so that we can find out solutions through our research. So what problems actually are? We are not having very specific markers on the basis of which I can predict the cancer risk in a particular patient of oral potentially malignant disorder. Also, we are not having specific markers which can predict the prognosis of oral cancer patient after therapy. One more thing, that when we face an individual with habit who has not got any lesions, it is difficult to convince this patient with the cancer risk assessment, or we are not able to tell the patient whether patient will develop cancer or not, because patient will say that I'm not having lesions at this moment, and therefore why would I develop cancer? So we are not having markers which can assess cancer risk in these patients. Now, when we look at oral cancer, we know that there are various etiological agents for oral cancer, like areca nut, tobacco, alcohol. For oropharyngeal cancer, there is HPV. So we thought that, does the clinical pathological characteristics of oral cancer associated with a particular habit, does it change? And why we would like to know this, because this may change the prognosis of that oral cancer associated with a particular habit, and therefore that patient may need a different therapeutic approach as well. To summarize this problem, we are not having molecular markers which can differentiate oral carcinogenesis associated with different habits. Also, most important thing, we are not having a more objective or molecular diagnostic technique which can give us an accurate and fast detection in patients with oral precancer and cancer. Also, we thought that, can we use biofluids such as saliva and serum, which could be more non-invasive or less invasive procedures for diagnosis of oral precancer and cancer? Having said that, we started working on these problems, clinical problems, through our research. So the first problem which we face, that we are not having enough specific markers which can predict the cancer risk in a patient with OPMD or in a patient with oral cancer. What we did, we started searching for certain markers, and we actually came across CD44 and ALDH1, which are cancer stem cell markers. What we did immunohistochemical analysis to find out the difference in expression of these markers in patients with OPMDs with and without dysplasia, as well as in patients with oral cancer with and without lymph node metastasis. Now, why was this? In OPMD patient, how can we assess the cancer risk? So based on dysplasia, but can we have a molecular markers to predict that cancer risk in patients with OPMDs? So what we did, in OPMD group, we divided it into two, that is with dysplasia and without dysplasia, and we tried to find if these markers expression differs in these two groups. In oral cancer, we all know that the prognosis of oral cancer, the major factor on which the prognosis of oral cancer or the recurrence of oral cancer depends on lymph node metastasis status. So we also tried to evaluate the difference in expression of these markers in oral cancer with and without lymph node metastasis. And through our research, we got very promising results. We found that ALDH1 in fact can be used as a specific marker for dysplasia, because we got its increased expression in patients with dysplastic lesions. Also, the expression was more in patients having higher grade of dysplasia. CD44, we got the expression of CD44 more in patients having lymph node metastasis. And therefore, we could conclude that CD44 can act as a prognostic marker in oral cancer patients. And if CD44 comes positive, that states that patient has got worse prognosis. So this answered our first problem in the clinical setting, that we can have certain specific markers on the basis of which we can predict the cancer risk in OPMDs, as well as we can predict the prognosis of oral cancer patients. Now, as we have discussed, we know that there are various agents, etiological agents responsible for oral cancer. And based on the etiological agent, the clinical presentation of oral cancer differs. For example, in case of smoking, the cancer of tongue and floor of mouth is more common. With tobacco chewers, the cancer of gingivo-buccal complex is more common. In oropharyngeal cancer, where HPV is the cause, the presentation differs. So the etiological agent is associated with different clinical presentation in oral cancer associated with that specific habit. So we thought that, can we have certain markers which can differentiate oral carcinogenesis associated with different habits? And to have a solution, to have an answer to this, what we did is we tried to find out molecular differences between oral cancer associated with different habits. Recently, we have found that oral cancer associated with SMF is on rise. So we tried to find the difference in clinicopathological characteristics of oral cancer associated with SMF and oral cancer not associated with SMF. What we found is that in the group of OLCC associated with SMF, the differentiation grade is better. That is, we found more well-differentiated oral squamous cell carcinomas in a group of cancer patients associated with SMF, while moderately differentiated and poorly differentiated squamous cell carcinomas were common in other group where it was not associated with SMF. Also, regional lymph node metastasis was less commonly seen in patients of oral cancer associated with SMF. So, through these findings, we came to a conclusion that definitely OSMF associated CA, they have better prognosis because the grade of differentiation was better in these patients. The lymph node metastasis was less in these patients, and therefore these patients can have better prognosis. So to confirm this, we actually thought of doing a molecular analysis where we chose certain aggressive markers like Ki67, matrix metalloproteinase 9, and alpha SMA. We tried to find the difference in expression of these markers in the two groups. As you can see in this bar diagram, the blue bar represents healthy controls. The red represents oral cancer patients associated with SMF. The third, that is green bar, represents oral cancer not associated with SMF. And to our surprise, what we found is that the expression of these markers was definitely more in patients of oral cancer not associated with SMF. So this established the fact that aggressiveness of the second group was more. That is, oral cancer, which was not associated with SMF, was a more aggressive group of cancer. And therefore, these patients would require a different treatment approach, a more aggressive treatment approach. So definitely there is difference in oral carcinogenesis associated with different habits, which we could prove through our research, through these research. Now, the next problem which we face in clinical settings is related with SMF. Oral submucous fibrosis is definitely caused by areca nut, and but recently we have found that the patients with SMF, they are consuming more and more processed areca nut, and that has increased the incidence of SMF as well as the oral cancer associated with SMF. So what is the problem associated with SMF? It is difficult to manage the cases of SMF. We have faced that in clinic. Definitely, oral submucous fibrosis is difficult to manage. Another problem that we are seeing more and more malignant transformation in SMF cases. So when we started looking at the literature and fibrotic disorders occurring in other parts of the body, we found that each and every organ can get a fibrotic disorder. The causes are many. Like in case of lung fibrosis, it could be because of smoking. In case of liver fibrosis, it could be because of hepatitis virus. In kidney fibrosis, it could be an autoimmune disorder. So the causes are many, but the result is fibrosis. And then we started thinking there could be a common pathogenic mechanism which could result in fibrosis or in all these fibrotic disorders. And then we thought of faulty angiogenesis. So we proposed that this faulty angiogenesis could also be the cause for chronic fibrosis in SMF. Now, what is the application of this proposal? It has been found through experiments that the inhibition of this faulty angiogenesis can actually treat liver and lung fibrosis. And therefore, we need more research which is based on, which can target the faulty angiogenesis in SMF, and we can treat these SMF patients in a better way. The next problem, what we thought was, what we come across is that we are seeing more and more cases of SMF transforming into CA. Definitely, areca nut is the cause, but the pathogenic mechanism, what we thought is the stiffness of the matrix, which results from chronic fibrosis and SMF. Now, you would ask me how matrix stiffness can result into carcinomatous changes. So we got the answer that stiff matrix can actually alter cell growth, can modify gene expression, can alter cell differentiation, can cause fibroblast transformation into myofibroblast, can cause epithelial mesenchymal transition, and so on and so forth. So what is actually wrong is the matrix stiffness in SMF, which causes malignant transformation in these cases. Now, what is the application of this proposed pathogenic mechanism? Actually, stiff matrix compromises treatment efficacy in SMF, and therefore, we need to have therapies that can actually sense and respond to mechanical cues related to stiffness of matrix in SMF, and therefore, if we come up with antifibrotic treatment modalities which can specifically target the stiff matrix, we can treat these patients in a better way, and we can also prevent the malignant transformation in SMF. Now, the next problem or the next thought process for us was, why can't we have a more objective way of diagnosing oral cancer? Why can't we have a more molecular way approach towards diagnosis of oral precancer and cancer? And also, can we use saliva and serum for diagnosis of oral cancer? And then we started thinking about optical spectroscopic techniques. Why we thought about these techniques? Because these techniques actually are based on biochemical changes taking place in the tissue. These techniques are inexpensive. They can utilize serum and saliva. They can give rapid analysis. Their results are reproducible, and they can also be used for mass screening. Here in optical diagnostics, diagnosis is usually based on biochemical changes underlying the pathology rather than visual or microscopic changes which take place at tissue level. So with clinical examination or with biopsy, with H&E staining, we usually have morphological changes, assessment of morphological changes. But optical diagnostics takes this further. That is, it assesses the biochemical changes associated with oral precancer and cancer, and on the basis of that, it can diagnose these disorders. So there were three main techniques in optical diagnostics. That is fluorescence, Fourier transform, infrared absorption, and Raman spectroscopy. So fluorescence, as we all know, that this technique is actually analyzes the fluorescence properties of a sample, and it determines the concentration of the fluorophore in that particular sample. It can be conducted in vivo, ex vivo, and it actually measures the fluorophores, naturally occurring fluorophores such as collagen, elastin, keratin, and NADH. And the basic principle lies in the fact that presence of disease can lead to changes in blood concentration, nuclear size, collagen content, epithelial thickness, which can alter the concentration and characteristics of fluorophores. And on this basis, we can diagnose precancer and cancer. So there are definitely a lot of research which happened in earlier years. But the major drawback of this technique was there are very few natural fluorophores which occur in oral tissues. And these fluorophores can have broad and overlapping spectra, which can reduce the specificity, which actually reduces the specificity of this technique. So to overcome this, people came across Fourier infrared transform infrared spectroscopy. This is based on the absorption and emission of molecules present in that tissue. It actually measures the vibrational frequency of the molecule, and on that basis, the spectra are analyzed. So on this also, after fluorescent optical diagnostic, there was a lot of research on this technique, but though it gave a very promising result that it gave a complete biochemical analysis of the tissue, but here water was the culprit. Water is an extremely strong FTIR absorber, and therefore it reduces the penetration depth. And this makes this technique less sensitive for diagnosis of oral cancer and precancer. And therefore, to overcome all these limitations of earlier optical diagnostic techniques, we came across Raman spectroscopy, which is actually also a vibrational spectroscopy, and it gives a detailed information about the chemical structure of that particular tissue. Why we thought of doing Raman spectroscopic analysis? Because it could use serum and saliva. It gives definitely a global biomolecular profile of the sample. It gives very specific biochemical, structural, and conformational changes taking place in tissues with oral precancer and cancer. Well before this is demonstrated, well before the clinical manifestations start occurring in these patients. So what we did, we collected the blood of patients with oral precancer and cancer, and our aim was whether we can diagnose the patients with oral precancer and cancer based on Raman spectroscopic analysis of their serum. Also, we thought that whether we can have diagnosis of leukoplakia or SMF based on Raman spectra. So accordingly, we chose our groups. We collected the blood sample. We separated the sera from the blood samples, and the sera was then subjected for Raman spectroscopic analysis. The advantage of this technique is that it gives results in a couple of hours. So it gives such spectra which are recorded and analyzed with the help of certain softwares, and the data we analyzed was related with certain molecules. That is, we assessed beta carotene, proteins, DNA, and amino acids. And these molecules, they actually give different peaks depending on the disorder. So we got results where we could actually differentiate between normal healthy controls, oral precancerous conditions and lesions, and oral cancer based on Raman spectra. That is, the spectra were different for healthy controls, the spectra were different for patients with OPMDs, and the spectra were different for oral cancer patients. To take it further, we also got results where we found different spectral features for patients with dysplastic lesions. Also, when we took the blood sera of individuals with adverse habits who did not had any oral precancerous or cancerous lesions in their mouth, these patients also showed certain other spectra which were different from healthy control. That is, we could actually assess the biochemical changes taking place in these patients without any lesion, but with habit without any lesion. We could find different spectra in these patients, though they did not show any lesion. So before the clinical appearance, before the lesions appear in the oral cavity, the biochemical changes are already taking place, and Raman spectroscopy can actually assess these changes. So through this research, we got a very good publication in a reputed journal, and we could conclude that serum can definitely be utilized for assessment of different oral potentially malignant disorders. To take this research further, we thought that why can't we assess saliva of these patients, and can we use saliva as a diagnostic tool for diagnosis of oral precancer and cancer? So we did a comparative analysis, that is, we collected sera as well as saliva of patients with OPMDs, and we subjected it for Raman spectroscopic analysis, and we got the results as sera can actually could give us better results as compared to saliva. Though these results are very preliminary based on few samples, we are still trying to get more and more samples, and we are working on this research through which we can come up with a robust data which can actually compare the serum and saliva as diagnostic tool for oral precancerous lesions and conditions, and as well as for oral cancer diagnosis. So through this research, through the Raman spectroscopic research, we actually could conclude that neoplastic cells, or even before the cells they transform into neoplastic cells, these cells, they show specific changes in quantities as well as in conformations of proteins, nucleic acid, carbohydrates, and lipids. And these changes get reflected in the spectral characteristics. And based on this, we can actually have a diagnosis of oral precancer and cancer. Also, before morphological changes occur, that is in a group of individuals who had habits but without any lesions, we could find spectral differences. So before the morphological changes occur, biochemical changes actually have started in these patients and these individuals, and Raman spectroscopy is very useful in assessing the cancer risk in these patients, and as it yields a global profile of biomolecular changes associated with carcinogenesis. So the findings obtained in this study provides a very reliable evidence on Raman spectroscopic discrimination of OPMDs and malignant from healthy controls, and therefore it can give it can provide us with the early diagnosis of oral cancer, which can actually reduce the morbidity and mortality associated with these patients with oral cancer. So what are the implications of the research based on Raman spectroscopy, what we carried out? Actually, definitely it can help in diagnosis of OPMDs and oral cancer. Definitely, we can assess the cancer risk in these patients. Also, we can predict progression of the disease in these patients based on Raman spectra. So, these techniques can be diagnostically useful, and we can actually screen the patients using the blood sera of these of patients with OPMDs and oral cancer, for the reason that this technique is cost effective. It utilizes serum and saliva, so which makes it less invasive. It is reproducible because it is computer-based analysis, and definitely in shorter time it can give results. So through all these research projects, what we actually could conclude is we could get the answers for our questions which we face in our clinical settings. That is, definitely we can come up with biomarkers which can help in diagnosis, which can help in cancer risk assessment and prognosis of patients with OPMDs and oral cancer. We can have change in trend towards the diagnosis of oral cancer, and we can think of other diagnostic techniques such as Raman spectroscopy for a diagnosis of oral precancer and cancer. Also, we can utilize biofluids such as saliva and serum, which can prove to be a potential diagnostic tools in patients with oral precancer and cancer. And with this, I hope to change or set the new trends in oral cancer diagnostics and therefore in therapeutics. With this, I would like to conclude, and definitely I would like to tell my budding dental professionals that we have a bigger responsibility as oral clinician, because it is rightly said that we as clinicians are working in the largest laboratory of clinical research, because we are associated with the illnesses of the patients, and therefore we can definitely think on the solution for these problems through our research, or at least we can collaborate with the researchers once we come across any problem in our clinical setting. So with this, I would like to thank team Asian Pacific Association for Dental and Oral Health for providing this platform. Thank you all for patiently listening.
Thank you so much, ma'am, for sharing your views and experience. We have some questions from our Number one question is from Abhay Kulkarni. He's asking, does smoking and smokeless tobacco associated cancer differ with nature too as severity prognosis?
Yes, that is what we tried to prove through our research. We conducted 3 studies related to this, and we tried to, first of all, we tried to find if there are any clinical and pathological characteristics in patients with SMF and in patients. The other group actually was CA associated with some other habits. So definitely there are prognostic differences, and this is because the oral carcinogenesis associated with a particular habit is different for a different habit. The prognosis differs with the habit, basically.
Ma'am, we have another question. SMF associated cancer are easily and early performed.
Easily and early?
Formed.
Yes, I mean, I think Dr. Abhay wants to ask that whether the malignant transformation in these patients is very fast. Yes, definitely the malignant transformation in these patients is very fast. That is what we have observed in our clinical settings. Patients with SMF, now coming with SMF, they have greater chance of malignant transformation, and what to blame for? The processed areca nut, because it has got lot of flavoring agents, lot of chemicals. Earlier people used to have raw tobacco, raw areca nut, but nowadays younger individuals, they are attracted towards more processed areca nut, and that has actually spoiled, that has actually increased the rate of malignant transformation in SMF.
Okay, ma'am. One last question.
Yes, ma'am.
Faulty androgenesis may be related to habits. Any way to check how to check faulty androgenesis?
Yes, we do have markers for angiogenesis like VEGF, and we can check the expression of these markers in these particular disorders, and through that, maybe we can have the confirmation whether the angiogenesis is faulty or is increased or is decreased.
Okay, thank you so much, ma'am. On the behalf
Thank
of
you.
Asia Pacific Association for Dental and Oral Health, I would like to express my gratitude to both the speakers for their presence, enlightenment, and ample contribution for making this webinar a wonderful, more informative, and interesting session. I would also like to extend a sincere gratitude to our participants for taking out their time from the busy schedule to grace the event. For the past participants, the certificate link is given in the chat box. You can download using the same link, and the steps are given there in the chat box. If any problem persists, a mail will be sent to your respective email IDs on the Monday for downloading the certificates. Thank you, everyone. Thank you so much.
Thank you all.
Thank you.
Have a great day ahead.
Thank you.